I'm Dr. Jonathan Strauss. I'm a radiation oncologist here at Northwestern, specializing in the treatment of breast cancer. And I want to talk for just a few minutes about when we use radiotherapy in breast cancer, how it's been changing over time, and what my practice is like here at Northwestern. In general, we use radiotherapy in three circumstances in breast cancer. Most often, after a lumpectomy or a breast-conserving surgery, most patients receive radiotherapy to clean up microscopic cancer cells that might be left in the breast. After a mastectomy, or removal of the whole breast, we will sometimes use radiotherapy to the chest wall or reconstructed breast and its lymph nodes if there's enough risk of microscopic cancer cells being left behind. And this very often depends on whether or not the lymph nodes are involved. Finally, for women with metastatic breast cancer, where the cancer may have escaped the breast and its lymph nodes, we will sometimes use radiotherapy to shrink down spots elsewhere in the body that are either causing pain or other symptoms, or that may in the future cause us problems. Radiotherapy has changed an enormous amount over the decade and a half that I've been using this treatment. When I was in training, it really was a one-size-fits-all approach. Almost every woman who was coming in after surgery was getting radiotherapy for about 6 or 6.5 weeks. Nowadays, the treatment duration is much more tailored and often much shorter. We learned that some women may be able to omit radiotherapy altogether. Some can do their treatment in a 1-week course, others in 3 to 4 weeks. For some women who still have positive nodes, we may still be doing a 5 or 6 week approach. More importantly than the timing, radiotherapy has gotten much safer over time. We have learned through a variety of techniques to do what we call cardiac sparing, to totally exclude the heart from the radiotherapy field. Most often, this can be achieved either with deep inspiration breath hold, taking and holding a big deep breath in the chest to push the heart away, perhaps with the prone position or using gravity to pull the breast away from the chest wall, through other delivery techniques, and even, if our standard techniques aren't working, through the use of protons. We also have gotten much better at reducing lung dose and reducing the radiation-related skin reaction or sunburn that comes on the breast. Here at Northwestern, we try to be on the cutting edge of all the changes that are going on in our field. We enroll women to a large variety of randomized trials. And what we're really trying to do as a field is find out who are the few women who may still have a risk of recurrence we don't like, for instance, women with inflammatory breast cancer, and enroll them in trials to increase the intensity of treatment to do better. For most women, we were doing extremely well in the risk of local recurrence in the breast. We're really trying to make treatment faster or gentler or safer. In my own research, just here at Northwestern, I'm looking at lymphedema prevention, what we can do through radiotherapy changes or in coordination with other doctors to try to minimize the risk of that dreaded arm swelling. And we're also looking at very early studies of biomarkers to try to see if there are serum markers that can help to drive radiotherapy decisions or inform us as to when we can omit radiotherapy in women who perhaps could get away without it. Overall, we have really transitioned and are continuing to transition away from a one-size-fits-all approach and towards a radiotherapy approach that tailors treatment to the patient and her cancer and does its very best to eliminate the cancer, but also to minimize or eliminate the risk of side effects from the treatment.